Great, thank you very much. Not much in this space has changed since a year ago, so I didn't see much of a need to change my talk. So we still need a new generation of stents. These are my disclosures. Now, renal vein compression etiology is obviously, the vein is compressed between the SMA and the aorta. It's called an anterior nutcracker, and more common in thin individuals, retroaortic renal vein, posterior nutcracker, and then you have the circumaortic, and then those patients who've had prior transposition. Symptoms are, majority are pelvic due to reflux of the gonadal veins. Pelvic varicosities are not actually common. The two things that we need to make sure we keep in mind is proteinuria and hematuria in this patient population. They could be because of this, but they're uncommon cause, and I will get to it in a second. Stent placement is not well accepted for the treatment of left renal vein compression, and the reason is because, number one, the data is scant. The second thing, the data is not that good. The reason the data is not good has to do with the technical issues and the stent migrations and the embolization. Many of it has to do with misplacement and mismatch of anatomy to the stent people decided to use, which most often in the literature has been Wallace stent. And there are issues with Wallace stents. We never put Wallace stent in this location. You're asking for trouble if you do that. And here's the sample literature. As you can see, there are a lot of case reports and small series like this. And look at the 75 patients, the first study by Wu and the colleagues, 5 migration. And the second one, 61 patients, 1 embolized to the heart, 1 migration, 1 misplacement. And you can see that the complications are not. You can't just ignore these complications, and that's why it has never been accepted as a treatment. The data should be more like the study, by Afterneros and the colleagues, but a small number of patients, but technically good study. So indications for renal vein stenting: recurrent or refractory symptomatic gonadal vein reflux. So I just want to emphasize that. In our practice, we really don't do anything to the renal vein in patients with gonadal vein reflux until it's refractory to all other treatments or it's recurrent. Refractory proteinuria, and I want to emphasize that term again, refractory, and hemoglobinuria, okay? So renal vein compression, pelvic venous disease, hemoglobinuria, and proteinuria all occur independently, and correlation has to be established before proceeding with the stenting. Renal vein stent placement should be the last step, in my opinion. Although it's a technically easy procedure and it's quick, you just have to make sure that the devices you use match the anatomy. But we have to make sure that the symptoms are in fact due to this. And I want to show you a case. It's a 33-year-old. Diffuse abdominal pain, pelvic varices, the usual stuff, okay? And the patient here has some mesenteric cysts, and the people have been sort of blaming her abdominal and pelvic pain and those mesenteric cysts. But the fact is that she's got bilateral, gonadal vein, in this case, ovarian vein reflux into her pelvis and large pelvic varices. So these were treated, and you can see on the initial venogram, you see the compression of the renal vein on the left side, and look at the large varices. And our practice is we usually use liquid embolics in these. And after 1 month, patient, all symptoms disappeared. However, at about 6 months, some of the symptoms started coming back, and at 10th month, she had symptoms again. MRV showed recurrence of the pelvic varices, and here's what it looks like. And you can see some of those coils and liquid embolics have been recanalized, and you have new pathways, and again, due to the severe compression of the vein. All of these were embolized again, and she did fine. Now the problem is that she developed microhematuria 7 months later. So now we are talking about, almost a year and a half later. And then at this point, we decided that we'll go ahead and stent it. So we embolize all of these things. You do your measurements and make sure the stent you use. Again, we don't use Wallace stents in these locations. And the stent was placed, as you can see right there. It's a 14 by 30 smart. There is a lack of good devices for this location, and that is the topic, and we'll talk about it in a second. And then pretty good, and you can see that the varices decompress, and all the symptoms abated completely, and they didn't come back. And here's the follow-up CT on this patient. This is an old patient, but we have follow-up on 16, 17 years on this lady. As you can see, stent, location and secure, and things are open. But there is on the panel, and you can see on your right side, the stent is somewhat compressed. Doesn't need to be completely open. We just need to obliterate the pressure gradient. That's about it. What that level is hard to know. I mean, nobody knows. But that seems to be sufficient. Now, another patient, then this lady, again, same thing, ovarian vein reflux. In this case, it was a retroaortic vein, and you can see the compression on the vein. And this patient had recurrence, and so we went ahead after the recurrence, stented it, and here's the IVUS on that side, which I can't play right now. Now, when you put the stent in, it looks not secure. As you can see, there's flow on the gap, sort of an Egyptian eye. So we put an IVUS in there, and if I could play the IVUS, that you could see that it is, and here's it on the table dyno CT that we did. Now you feel more comfortable that this thing is in fact secure, and that segment does remodel over time. And this is the IVUS that you can see that a little bit of a sort of an Egyptian eye sort of configuration that you can see. And here it is at follow-up, that you can see the entire thing has remodeled and secure. Again, it has to do with matching the device to the disease and the anatomy. Now, I want to show you sort of the difference. There's no need to put the stents that far into the IVC. You got plenty of room, and you don't need to go into the hilum of the kidney either. You just have to make sure you use the right stent in these locations. So why is this? We don't have good devices. The renal vein characteristics, they're short, 4 to 6 centimeter. Typically, we use 4 or 3 centimeter long. There's a sharp angle of convergence into the IVC. Balloon expandable stents and wall stents we don't use. Generally, we use biliary stents, 14 diameter, 3 or 4 centimeter long. Dedicated venous stents have a stiff, large delivery system. It's hard to secure in that location and judge the landing. And the short ones are missing. Better delivery system. Self-expanding open cell nitinol stents are my preference. You have to improve the profile because of that sharp turn and retain compression resistance. Of course, the dimensions about 3 to 4 centimeter, 12 to 14 in diameter. In conclusion, in experienced hands, renal vein stenting is safe and effective. You just have to make sure you use the right equipment in the right patient. Mid and long-term outcome data remains scant, although current generation of stents may be good enough, they're not optimized. Thank you.